Hi everyone. In this recording, we are going to talk about endocrine problems. So problems in the endocrine system result in either elevated or depressed hormone levels. This can be caused by many things. It could be failure of feedback systems, could be dysfunction of the gland itself. It could be dysfunction of a trigger gland, such as the pituitary gland. It could be that the gland itself can't make the hormones because it can't get the precursors to the hormone. Or it could be that it just makes too much. It could be a tumor. That would be ectopic hormone release outside of where it's supposed to be. Or it could be that the liver is metabolizing the hormone too fast. Many different causes. Could also be target cell failure. Every hormone has a target cell. That is the definition of a hormone. It is produced by one gland, and it doesn't act upon that gland, but rather somewhere else in the body. And those are our target cells. So if those target cell receptors aren't working correctly, then the gland is going to be seen as not functioning correctly. And we will talk about that when we talk about thyroid problems. And also type 2 diabetes is target cell failure. So in type 2 diabetes, for example, the target cells are all of your body cells, and they develop resistance to the hormone insulin. Insulin is a carrier protein that brings glucose into the cells. And if the cells become resistant to it, that's when we have type 2 diabetes. Now that's distinguished from type 1 diabetes, which is gland dysfunction, because we do have a destruction of the beta cells in the pancreas. So first up, we're going to talk about pituitary disorders. And with the pituitary, we've got two lobes. You've got your anterior lobe, which produces many hormones. And then you've got your posterior lobe, which is just two of them. So we're going to start with the posterior lobe, and we're going to talk specifically about vasopressin, which is antidiuretic hormone. Okay? So if you have too much antidiuretic hormone, then we call it the syndrome of inappropriate antidiuretic hormone. And when we see this, our symptoms are related to the fact that your kidneys are not excreting any water. Now remember that antidiuretic hormone works without touching sodium, and so it is just water retention. And your patient is extremely swollen, and all of that extra water on board means that everything in the body is very dilute. So your sodium levels are very low. You've got hyponatremia. You also have what we call hypoosmolality. Osmolality is a concentration within the blood, and it takes into account a lot of our electrolytes, but the primary one is sodium. And so anytime you have hyponatremia, you're also going to have a low serum osmolality. We call that serum osmo for short. Now the urine, on the other hand, in somebody with SIADH is super concentrated. It's very dark. It's very heavy because there's lots and lots of solutes in it. So that sodium level is going to be very high, which means that the urine osmo will also be very high. When we talk about weight of urine, we call that the specific gravity. And the specific gravity will be very high in somebody with SIADH. Anybody who has really concentrated urine, the more concentrated the urine is, the higher the specific gravity is. Everything is judged with specific gravity. Everything is judged in relationship to water. Water has a specific gravity of 1. So urine is always heavier than water. And so urine specific gravity is going to be greater than 1. It's like 1.0 something. It's not like it's going up into the 2 and the 3. But somebody with SIADH will be significantly higher on the specific gravity. So this patient's going to have swelling. They're going to have hyponatremia. When we have sodium problems, remember we look for changes in LOC, so we may have neurologic symptoms. Okay? So we treat it with diuretics. We have to pull that fluid off. Sometimes we will give them a little bit of hypertonic saline to help adjust the sodium level. These patients are also on a major fluid restriction, 300 to 500 milliliters per day sometimes. Depends on the patient, okay? They are thirsty, but not as thirsty as you would think, because thirst is triggered by receptors that look at serum osmo. Our chemoreceptors in our brain and our carotid arteries look at our sodium levels, and they look at how concentrated our blood is. And these patients, their blood's not that concentrated, so it doesn't trigger as much of a thirst symptom as you would think, even though they're on that fluid restriction. And then we have to treat the cause, okay? Remember that with SIADH, our cause often is cancer, and your patient may not have already been diagnosed with cancer. This may be what brings them in. Another potential cause can be a traumatic brain injury, which hits the pituitary and causes the posterior pituitary to release a lot of antidiuretic hormone, for example. But a lot of times SIADH is seen in the presence of cancer. And we do call that a paraneoplastic syndrome. I'm actually going to write, nope, I can't. I was going to try to write it on there, but I can't do that. So it's called a paraneoplastic syndrome, meaning that it occurs related to cancer. All right, on the complete end of the other end of the spectrum, we have diabetes insipidus. This is when your patient has not has no ADH. Okay, so in SIADH, they were retaining all this water. In DI, they can't stop peeing. Okay. The term diabetes means polyuria and polydipsia, excessive urination and excessive thirst. This is diabetes insipidus. The diabetes that we refer to just as diabetes is diabetes mellitus, okay, mellitus. But both of them have as characteristics polyuria and polydipsia. In here, we don't have enough ADH, and so the kidneys cannot concentrate the urine. Okay, and the majority of the time it's a neurogenic DI, which means that the pituitary gland is not making enough ADH. You can also have nephrogenic and psychogenic. Those are rare. Nephrogenic is your pituitary gland's okay. It's just that your kidneys aren't responding to it well. Now, our manifestations here, this is exactly the opposite. And so our symptoms of DI are going to be related to, instead of water retention, water excretion. So your patient's going to be very dehydrated. Your patient's sodium level is going to be super, super high, which means that their serum osmo will also be super high. And their urine is going to be extremely dilute. It is going to have a very low sodium level within the urine. The urine osmo will be very low. The urine-specific gravity will approach that of water. It can't be that of water because there's always some solutes in it. Now, the cause for DI is almost always brain surgery of some sort. So the removal of a pituitary tumor, for example. Now, a lot of times it causes a transient diabetes insipidus that we treat, and then the patient recovers and the pituitary gland kicks in again. We do have medications, okay? We have synthetic ADH, it's called vasopressin. That's shown here. Vasopressin is an injection. Desmopressin comes as an injection, but it also comes as a nasal spray and as tablets. And these two medications mimic antidiuretic hormone. And so in lower doses, what we're going to do is we are going to give this medication to our patients with DI. We're also going to give them a lot of IV fluids, and we're going to encourage them to drink. Okay. And you'll see the effects of this pretty quickly. Once we get this in their system, their kidneys will start resorbing water, and they'll start concentrating the urine more. Their urine will get darker. It'll get more yellow. The output will decrease, so they won't be putting out nearly as much urine. We also use vasopressin in the treatment of severe hypotension, such as that we see in code situations. And that is because so large doses, much higher doses of vasopressin cause vasoconstriction. And so we can give that in a code situation to help keep somebody's blood pressure up. It is also used sometimes to treat esophageal varices, but more often to treat bedwetting in children, or I guess in adults. I've never really thought about that. This often is the nasal spray because a lot of times kids can't take pills. And they do a nasal spray of desmopressin at bedtime. And what it does is it keeps the kidney, it makes the kidney resorb extra water, so the kidneys are producing less urine overnight, which means the bladder doesn't get as full, which means that the child doesn't wet the bed. By morning, the medication has worn off, the kidneys have started to produce more urine, but now the child is awake. That was specific to ADH and the posterior pituitary gland. Once we get and we look at the anterior pituitary gland, we have a lot more hormones there. So hypopituitarism is the lack of production of one or all of your pituitary hormones, your anterior pituitary hormones, okay? If it's a deficiency in all of them, we call it pan-hypopituitarism. Pan means all, okay? Hypo is low, right? And so you're going to have deficiencies in ACTH, TSH, FSH, LH, and GH, which is growth hormone, okay? Now this can happen due to a pituitary infarction. Remember, an infarction is death of tissue. So some of the pituitary tissue will get infarcted. It'll get ischemic and it'll get infarcted. This can happen with hemorrhage and shock because your blood pressure is super, super low. Sheehan syndrome is a condition. It's a pituitary infarction still, but it is specifically to hemorrhage during childbirth, during or after childbirth. So it's still a hemorrhage. It's just specific to childbirth that it is that causes the pituitary infarction. Couple medications that we have. Now, these are synthetic ACTH and synthetic growth hormone. So concentropin is synthetic ACTH, and we know that ACTH stimulates the release of cortisol from the adrenal cortex, okay? And we don't usually give people concentropin because it's an injection. And so if their adrenal glands aren't working, then we generally just give them the steroids, the glucocorticoids and the mineral corticoids that they need. But we do use concentropin to diagnose if somebody's adrenal glands aren't working, and you will hear in a different narration, that is called Addison's disease. We need to find out if it's the adrenal glands, if that's making somebody not have any cortisol in their body, or if it's the pituitary gland. So if the pituitary gland is malfunctioning, you've got hypopituitarism, for example, then the adrenals are just waiting for some instruction. So the end result is that we diagnose it as primary versus secondary. And we still treat it the same way, and that will be in a different video when we talk about supplementing our steroids. However, we do diagnose it this way so we can determine whether it's the pituitary and then they could be having other issues, or if it's the adrenal glands themselves. Now, we do sometimes give cosyntropin for HIV wasting syndrome, and that is because we know that they often have insufficient stimulation of their adrenal glands. And so we will give them some steroids, but we also try to stimulate their adrenal glands. Now, remember that ACTH, once it is released, that it triggers cortisol, and cortisol causes sodium and water retention, which means that you can get edema and hypertension. And we'll talk about that more when we talk about the adrenals. Now, synthetic growth hormone is called somatropin. Growth hormone is more than just skeletal growth. Growth hormone is responsible for a lot of processes. Even after you stop growing, you still need growth hormone, okay? But we give recombinant growth hormone to children who have a hypopituitary dwarfism. This is not the same as the achondroplasia mutation. The dwarfism that everybody thinks of is actually the achondroplasia. It's a genetic mutation, okay? People who have dwarfism due to deficient growth hormone, once we fix the growth hormone, then they will start growing again, okay? So as an example, a friend of mine, his son got brain cancer when he was 8 years old, and he is cancer-free, but he has to continue to take growth hormone injections because his pituitary gland no longer secretes it. He would have never grown. He would have never hit puberty. None of that would have happened without growth hormone. The way we monitor it is we keep a journal. We measure weight. Typically, weight is checked once a week on somebody who we're trying to get to gain weight. And height, we check it about once a month. You don't typically grow enough in a week to check height. Okay, hyperpituitarism, often caused by a pituitary adenoma. And it can change, it can result in extra secretion of a variety of hormones. A pituitary adenoma doesn't usually cause SIADH, though, like I was saying earlier. That is usually a traumatic brain injury or cancer. Hyperpituitarism, this way, we are talking about excessive release of one of our anterior pituitary hormones. Now, we will talk about what happens if it's ACTH when we talk about the adrenals. We'll talk about what happens when it's TSH when we talk about the thyroid. For right now, we're going to talk about hypersecretion of growth hormone. Now, anytime you have a pituitary adenoma, remember that this is a tumor in your brain, and so it will cause a headache. It will cause fatigue. Sometimes you'll get visual changes because it is very near the optic nerve. And wherever it is growing, it may be releasing the hormones. It may be pushing on part of the pituitary to release hormones. It may also be obstructing part of the pituitary from releasing its hormones, okay? So the moral of the story is they have to remove it. You have to remove a pituitary adenoma so that it doesn't mess with the hormone levels. Now, hypersecretion of growth hormone, we've got two names here. If it happens in children and adolescents, we call it gigantism. And that's because the epiphyseal plates of the long bones are not yet sealed. And so their long bones, their femurs, their arm bones, their tibias, their fibulas, all of those things can still grow. And so they are very tall. In this picture, you've got two people who are normal sized. You have somebody with gigantism and you have somebody with dwarfism in this picture. So you can see this guy's a couple feet shorter than these two, and he is a couple feet taller than those two. Now, if you've got hypersecretion of growth hormone after puberty, once the epiphyseal plates in your long bones seal, it's several years after puberty, but in adulthood, basically, we call it acromegaly. because the long bones don't grow. Instead, what grows are your hands and feet, your nose, your chin, your brow ridges. Okay, so this is the same woman. This is a long time ago, but you can see her features changing over time as her brow ridges get heavier, her nose is getting bigger, her chin has changed a lot, gotten a lot bigger, and her hands are what I refer to as man hands. Okay, so we will see this if those epiphyseal plates are closed, because they're still responding. Okay, these bones are still responding to that hypersecretion of growth hormone. Now, we don't generally see this today because if somebody does have a pituitary adenoma, we remove it. Okay. One anterior pituitary drug, one that affects it here, octreotide. So octreotide is a medication that stops carcinoid syndrome. Okay, carcinoid syndrome is down here. The big thing with carcinoid tumors and carcinoid syndrome is that they sometimes secrete VIP, which is vasoactive intestinal polypeptide. And VIP causes profuse watery diarrhea. A ton of this watery diarrhea, okay? And so it is very dangerous for somebody who is who's already malnourished, okay? Because they've got cancer, right? And so we have to be very careful with those patients. And so this is life-threatening. It causes in addition to diarrhea, it does cause hypotension. Then they get dehydrated, which causes their blood pressure to drop even more. So octreotide reduces those symptoms, okay? Now, octreotide does affect the blood sugar. Interestingly enough, it can cause it to be up and down. They're just very labile. Their blood, did I say blood? Yeah, blood sugar. I forgot if I said blood pressure. So we do monitor glucose levels very closely in all of those patients. Now, more often, you are going to see octreotide used for GI bleeds from esophageal varices because it does decrease portal hypertension. Remember, that's the pressure of your portal system in your liver, your blood vessels in your liver. And that pressure in your liver is what makes the varicose veins, that's what esophageal varices are, varicose veins in your esophagus. And that portal hypertension is what pushes that pressure inside those veins. And so we give them octreotide, it decreases that pressure, which means they're going to bleed less. So you will actually probably see octreotide given for a GI bleed more often than you're going to see it given for carcinoid syndrome. All right, last thing here, if you have a prolactinoma. So this is a benign tumor that secretes prolactin. And in women, this causes amenorrhea, which is lack of a menstrual cycle, galactorrhea, which is milk production when somebody didn't just have a baby, hirsutism, which is male pattern hair growth on a woman, and osteopenia, which decreases the calcium in your bones. That is the step before we call it osteoporosis. In men, increased levels of prolactin basically counteract testosterone. So we see hypogonadism, we see ED, impaired libido, low sperm counts, and diminished ejaculate volume. All right, that's going to be it on this recording. And in the next one, we're going to talk about thyroid problems.